let's talk about APHINITY. I don't know, Rashmi, what do you think of APHINITY? You know, the stuff that the Martine Picard presented at San Antonio 6 months ago.
Yeah, sure. So, I think that was a really nice update on the previously presented study. And, my biggest takeaway from that was the benefit of pertuzumab is seen more so in the node-positive patients. So currently I'm strongly advocating for my node-positive patients to continue pertuzumab for a duration of 1 year. Now, in the node-negative patients, I think it opens up a little bit of a question as to whether we should advocate for them to get HP maintenance or just H alone. And so I think that becomes a point of discussion with the patient. But definitely strongly encourage my node-positive patients to continue it for a whole year. The other interesting piece that came up in APHINITY is the fact that, in the updated analysis, there's really no difference seen between the hormone receptor positive or hormone receptor negative.
If you look at the forest plot in the New England Journal, there's absolutely no difference for benefit of pertuzumab and APHINITY based on steroid receptor status. The confidence limits are completely overlapping. The point estimates are very similar. And so that was incorrect.
There's been some random stuff that's been presented every so often that somehow, if you're a specific luminal subtype, you get more benefit from pertuzumab. That was like wandering around in neoadjuvant circles for a while. I don't remember what happened.
Hasn't been shown in the APHINITY data.
Right,
Yeah.
it wasn't. No, I agree. But maybe I was thinking maybe that where some of that came from. I don't even remember. But anyway, so keep going. Sorry about that. So Rashmi, we interrupted. So keep going. Yeah.
Yes. So that
No,
those were I think
back to APHINITY.
I think those were my two key takeaways was really adjuvant pertuzumab for node positive and really not differentiating between use of it versus not based on hormone receptor status. So
right. So let's go a little bit further with this. We're in the era now where neratinib has been approved for this, for post-neoadjuvant therapy, and are we using it? Are we using neratinib in people? And if so, who? Carey, let's start with you, because you being the brain person probably uses more neratinib than most of us. So.
Sure. I think one of the things about the APHINITY data, just to take sort of a step back to where we even get to the end of a year of HER2-directed therapy, is the majority of us are giving TCHP neoadjuvantly. Unless something happens where medical oncology isn't consulted early on, we're probably going to lead first with TCHP, which makes the transition to post-operative less common. So I think the issue with the APHINITY data and how it leads into ExteNET is the majority of us would have given TCHP in the neoadjuvant setting. So, I think the APHINITY data is very helpful for us to understand, and I think we're seeing the separation of the curve more at the 6-year follow-up than we did at the 3-year follow-up. But it's not necessarily the same place that we would be in to make the decision about adjuvant neratinib, because those patients did not receive a full year of pertuzumab before benefiting from an additional year of a tyrosine kinase inhibitor. So I think that's been my biggest struggle with the ExteNET data, is just knowing that it followed a year of trastuzumab, not a year of trastuzumab pertuzumab. So then I don't know what that added additional benefit would be.
So let me ask you a question though. The fact that the curves in APHINITY separate late, does that make you guys think it's probably the triple positive clones that are driving this now? It's not really the, usually with an ER negative HER2 positive disease, someone's going to either get their disease and relapse in 3 years or they're not. So when I start to see these late relapses, to me it thinks, man, maybe it's like kind of the triple positive stuff. Any comments on that from anybody? Virginia, what do you think?
I think you're right. I think, to Carey's point, when you look at ExteNET, there was no or very little pertuzumab. There's no TDM1, and we'll talk about that as well. But we're always going to have gaps in data. And so we have to do the best we can with the gaps we have, because we're not going to ever have an ExteNET, future ExteNET where patients get pertuzumab, get TDM1, and then get randomized to whether they, to neratinib versus not. And so I typically will give neratinib. My main concern is diarrhea. Now the control trial was just published, and so we have data on what to do, but we still have pretty high numbers of grade 1 and 2 diarrhea, which for patients after being on over a year of therapy, it's pretty hard for them to tolerate.
Yeah, no, I agree. That's the big issue. Although there is some pretty good data, it's not without, I don't think it's TCHP, it's a little bit, Michael Gannat, I don't know if it's ever been published, but Michael Gannat presented, I think it's San Antonio or ESMO 2017, an analysis of people who had neoadjuvant, like 100, I mean, I think what ExteNET was, what, like 2,500 people, 2,000 people. You know, I think 10% of them had neoadjuvant therapy. And he looked in the post-neoadjuvant setting and did have substantial benefit, actually, to the people who had residual disease in the post-neoadjuvant setting. So it gives us something to think about in the way, you know, as Carey was saying, we treat people like this. But no, I agree. And, you know, the other thing, again, if the people who are relapsing are the ones later out that are triple positives, that's who actually the tyrosine kinase inhibitors are going for, right? That's usually where most of the benefit was. So Mark, what do you think?
You know, I think for a high risk patient, you know, certainly stage 3 disease or 4 more positive lymph nodes in a young age, those are the patients where I think about adjuvant neratinib. And those patients may have already had both antibodies and post-neoadjuvant TDM1, but if they have stage 3 disease, you know, in as much as ExteNET is now FDA approved, I feel obliged to have a balanced discussion with those patients about the risks and the toxicities. But now in the wake of the control trial publication and the escalation of neratinib dosing early on to mitigate against lower GI toxicity, you know, I think it can be managed in very high risk patients. In lower risk patients, I don't think the risk benefit ratio is favorable for extended adjuvant neratinib.
Totally agree with you.